Hey, this is Lisa. I know you're getting ready to start your next session of Select Connects with Clinicians, but first, I think we should do a quick warm up and review key points from the previous session. In the previous session, we reviewed the patient tracking domain. Let's take a look at a couple key concepts from that domain. For the OASIS item MO18, the response should reflect the NPI, or the National Provider Identifier, number of the physician who will be signing the patient's plan of care. Now, this can get confusing because patients often have multiple healthcare providers. Even if this item is populated by an electronic EMR, the clinician will want to be assured that the physician number reflected in M0018 is truly the provider who will be signing the plan of care. If the clinician is unsure, he, she, or they should consult with the home health agency's management. Item MO030 intends to reflect what is the date of the start of care visit. Now, as you will see, this will differ a little bit from the MO090 date. In multidiscipline cases, coverage criteria and regulatory requirements such as the conditions of participation and agency policy establish which discipline's visit will be considered the start of care. A reimbursable service must be delivered in order to be considered the start of care. All other coverage criteria must be met for this initial service to be billable and established as the start of care. To finish this warm-up, we want to point out something about the OASIS items M0050 and M0060. These items are where the clinician indicates the patient's state and zip code. Now, please note, after an injury or an exacerbation of illness, patients may become displaced from their typical permanent place of residence. In situations where this may occur, these OASIS items should reflect where a patient is residing as they are receiving care from the home health agency. Okay, everybody, that's it for our warm-up. Enjoy today's session.
Welcome everyone to the third session of Select Data's OASIS training. My name is Deborah Johnston and I am your host today. Material during this series will be delivered by members of the Select Data Clinical Leadership Team. Before getting started, I'd like to remind you of our disclaimer. Information made available from this webinar should not be considered legal advice. It is for educational purposes only and does not provide all available information on the subject. Information shared is not a promise or guarantee, expressed or implied. The opinions expressed, discussions undertaken, and materials provided do not represent an official position of Select Data. This module covers all of the OASIS items related to clinical records, M0080 to M0150 to M11, which is in living arrangements domain, and the OASIS items of the sensory domain, M1200 and M1242.
M0080 Intent, Time Points, and Data Sources. M0080 Item Intent specifies the discipline of the clinician completing the comprehensive assessment during an actual visit to the patient's home at the specified OASIS time point, or the clinician reporting the transfer to an inpatient facility or death at home. This is completed at all time points. Data resources would be the agency policy. Additional information can be found in Chapter 1 of the OASIS Guidance Manual. M0080 says discipline of person completing the assessment, and the options are RN, PT, SLP, ST, or OT. While only the assessing clinician is responsible for accurately completing and signing a comprehensive assessment, he, she, or they may collaborate to collect data for all OASIS items if agency policy allows. Enter the response associated with the discipline of the individual completing the assessment, referred to as the assessing clinician. According to the Comprehensive Assessment Regulation, when both the RN and the PT or SLP are ordered in the initial referral, the RN must perform the start of care comprehensive assessment. An RN, PT, SLP, or OT may perform subsequent assessments. LPNs, PTAs, and COTAs, and medical social workers and home health aides do not meet the requirements specified in the Comprehensive Assessment Regulation for disciplines authorized to complete the comprehensive assessment or collect OASIS data. MO090 Intent, time points, and data sources. The intent is it specifies the actual date that the assessment is completed. Time points, it is complete. This item is completed at all time points, and the data resources would be the calendar. MO090 says date assessment completed. If the date or month is only one digit, that digit is preceded by a 0. For example, May 4th, 2019 would be 05042019. Enter all 4 digits for the year. Date assessment completed cannot be before the start of care date. If agency policy allows assessments to be performed over more than one visit date, the last date, when the final assessment data are collected, is the appropriate day to record. The MO090 date assessment completed will indicate the last day that the clinician gathered or received any input used to complete the comprehensive assessment document, which includes all OASIS items. The comprehensive assessment is a legal document, and when signed by the assessing clinician, the signature serves as an attestation to the best of his or her knowledge that the document, including OASIS responses, reflects the patient's status as assessed, documented, and or supported in the patient's clinical record. Some OASIS items, for instance, the clinical record items like patient name, birth date, Medicare number, etc., may be completed initially by clerical staff as part of the intake and referral process, but should be verified by the assessing clinician when completing the assessment. For OASIS items requiring a patient assessment, the collaborating healthcare providers, for example, other agency staff, like an LP, an LPN, an LVN, PTA, COTA, MSW, and home health assistant, should have had direct in-person contact with the patient or have had some other means of gathering information to contribute to the OASIS data collection. Healthcare monitoring devices, video streaming, review of photograph, phone call, etc. When collaboration is utilized, the assessing clinician is reported for the considering available input from those other sources and selecting the appropriate OASIS items responses within the appropriate time frame and consistent with data collection guidance. MO090, date the assessment completed, will indicate the last day the assessing clinician gathered or received an input used to complete the comprehensive assessment document, which includes the OASIS items. Any exception to this general convention concerning collaboration is identified in item-specific guidance. If the assessing clinician gathers additional information during the assessment time frame that would result in changing the coding of one or more OASIS items, for instance, identifies functional or cognitive information that he or she believes is more representative of the patient's usual status than the code originally selected, the MO090 date should be changed to reflect the date of the last information was gathered and the response the response change was made. If an error is identified at any time, it should be corrected following the agency's correction policy, and the MO090 would not necessarily be changed. See information on Mo100 reason for assessment for additional clarification. Mo100 Intent, time points, and data sources. Mo100 item intent identifies the time point, which is the reason why the assessment data are being collected and reported. Accurate reporting of this response is important, as the logic in the data reporting software will accept or reject certain data according to the specific response that has been entered in this item. This is collected at all time points. Data resources for this would be agency case manager or the care team provider, a clinical record, or hospital and other healthcare provider information regarding the transfer to inpatient facility or death at home. Mo100, the item states, this assessment is currently being completed for the following reasons. Option 1, start of care with further visits planned. Number 3, resumption of care after inpatient stay. Option 4, recertification or follow-up assessment. Option 5, other follow-up. Option 6, transfer to an inpatient facility, patient not discharged from the agency. Option 7, transferred to an inpatient facility, patient discharged from the agency. Option 8, death at home. Option 9, discharge from the agency. You will enter only one response for this item. Response number 1, this is the start of care comprehensive assessment. A plan of care is being established whether or not further visits will be provided after the start of care visit. This is the appropriate response anytime an initial HIPS code for a home health resource group is required. Response 3, this is a comprehensive assessment that is conducted when a patient resumes care following an inpatient stay of 24 hours or longer for reasons other than diagnostic tests. Remember to update the patient tracking sheet ROC date in Mo030 when this response is entered. When a patient is discharged from an inpatient facility and care is resumed within the last 5 days of the episode, that is, the recertification assessment is due, the ROC assessment rather than a recertification assessment is completed. Response 4. The comprehensive follow-up assessment is conducted during the last 5 days of the 60-day certification period and is completed to continue the patient's services for an additional 60 days of care. Response 5. This comprehensive assessment is conducted due to a major decline or improvement in the patient's health status occurring at a time other than during the last 5 days of an episode. This assessment is done to reevaluate the patient's condition, allowing revision to the patient's plan of care as appropriate. Response 6. This transfer to an inpatient facility OASIS is completed when the home care patient is admitted to an inpatient facility for 24 hours or longer for reasons other than diagnostic tests, with the exception that home health care will be resumed following the inpatient discharge. Thus, the patient is not discharged from the agency. When the patient resumes care, a resumption of care comprehensive assessment is conducted. This response does not require a home visit. A telephone call may provide the information necessary to complete the required data items. Short stay observation periods in a hospital, regardless of duration, do not meet the definition for transfer to an inpatient facility. Response 7. Transfer to an inpatient facility. OASIS is only completed when the home care patient is admitted into an inpatient facility for 24 hours or longer, for reasons other than diagnostic tests, and the agency does not anticipate the patient will be returning to care. The patient is discharged from the agency. This response does not require a home visit. A telephone call may provide the information necessary to complete the required data items. No additional OASIS discharge data are required. Short stay observation periods in a hospital, regardless of duration, do not meet the definition for transfer to an inpatient facility. Response 8. Data regarding inpatient death anywhere other than death in an emergency department or inpatient rehab facility. A patient who dies before getting treated in an emergency department or before being admitted into an inpatient facility would have this response entered. Note the skip pattern included in the response. A home visit is not required to enter this response. The information necessary to complete the data items may be obtained by telephone. Response 9. This comprehensive assessment is conducted when a patient is discharged from the agency for any other reason other than to transfer to an inpatient facility or death at home. This response includes a transfer and discharge to another home health agency or an in-home hospice. A patient visit is required to complete this assessment. Note the skip pattern present in the response. The discharge OASIS is not required when only a single visit is made in a care episode, for example, like a start of care or resumption of care, directly to transfer or discharge. Assessment strategies. Why is this assessment being conducted or the information being recorded? What has happened to the patient? Accuracy of this response is critical. Mo102 Intent, time points, and data sources. Mo102 Item Intent specifies the date that home care services are ordered to begin or to resume following an inpatient stay of 24 hours or longer and for reasons other than diagnostic tests, if a start of care and resumption of care date was specified by the physician. The item refers to the order to start home care services, that is, provide the first covered service, or to resume home care service, that is, provide the first visit following a qualifying inpatient stay, regardless of the type of service ordered. For example, if it were a therapy only start. Time points completed. This would be completed at start of care or at resumption of care. And the data source would be the physician order to initiate home care or resume home care following an inpatient stay. Mo102 reads, data physician ordered start of care or resumption of care. If the physician indicated a specific start of care or resumption of care date when the patient was referred to home health services, record the date specified. If the originally ordered start of care or resumption of care is delayed due to the patient's condition or physician request, for example, if the hospitalization is extended, then the date specified on the updated or revised order to start or resume home care services would be considered the date of the physician-ordered start of care or resumption of care. For example, a patient discharged home on May 15th, but for whom the physician orders home care to begin on May 20th for a specified order, for example, PT or to administer a subcutaneous drug, would have a physician-ordered start of care date of May 20th. If the date of the month is only one digit, then the digit will be preceded by a 0. For example, for May 4th, 2019, you would put 05042019. Enter all four digits of the year. You will mark NA if the initial orders did not specify a start of care or resumption of care date. In order to be considered a physician-ordered start of care or resumption of care date, the physician must give a specific date to initiate or resume care, not a range of dates. If a single date to initiate or resume services is not provided, the initial contact via the initial assessment visit or resumption of care visit must be conducted within 48 hours of the referral or within 48 hours of the patient's return home from the inpatient facility. Mo104 Intent, time points, and data sources. The MO104 item intent specifies the referral date, which is the most recent date that the verbal, written, or electronic authorization to begin or resume home care is received from the home health agency. Time points completed. Resumption of care or start of care. Data sources or resources, the agency referral form, agency records specifying the date that the referral was received by the agency, or the hospital or nursing home discharge information. MO104 says the date of referral. Indicate the date that the written or verbal referral for initiation or resumption of care was received by the HHA. A valid referral is considered to have been received when the agency has received adequate information about the patient. This would include name, address, contact information, and diagnosis and/or general home care needs. And the agency has ensured that the referring physician or another physician will provide the plan of care and ongoing orders. In cases where home care is requested by a hospitalist who is not going to be providing an ongoing plan of care for the patient, the agency must contact an alternate or attending physician. And upon agreement from this following physician for referral and or further orders, the date will note this as the referral date in MO104, unless referral dates are later updated or revised. If the start of care or resumption of care date is due to the patient's condition or physician request, for example, extended hospitalization, then the date the agency received the updated and or revised referral information for home care services to begin would be considered the date of referral. This date does not refer to calls or documentation from others, such as an assisted living facility or staff or family, to contact the agency to prepare the agency for possible admission. The date authorization was received from the patient's payer is not the date of the referral. For example, the date of the Medicare Advantage case manager authorized service is not considered the referral date. Again, let me repeat. The date authorization was received from the patient's payer is not the date of the referral. If the date or the month is only one digit, you're going to write that with the preceding 0. For example, May 4th, 2019 would be 05042019. Enter all 4 digits for the year. Mo110 Key Terms: adjacent episodes, early episodes, and late episodes. The word adjacent means that there was no gap between Medicare covered episode more than 60 days. Periods of time when the patient is outside a Medicare payment episode but on services with a different payer, such as an HMO, Medicaid, or private pay, are counted as gap days when encountering the sequence of Medicare payments episodes. Early includes only PPS episode in a single calendar case or the first or second PPS episode in a sequence of adjacent episodes. Later means the third or later PPS episode in a sequence of adjacent episodes. Again, an early episode is the only PPS episode in a single episode case or the first or second PPS episode in a sequence of adjacent episodes. Later means that it's the third or later PPS episode in a sequence of adjacent episodes. Mo110 Intent, time points, and data sources. Mo110 item intent identifies the placement of the current Medicare PPS episode in the patient's current sequence of adjacent Medicare PPS payment episodes. The time points this is completed is the start of care, a resumption of care, or during follow-up. The data resources would be the Medicare systems, such as the health insurance query for home health, which is referred to as the HIQH. MO110 says episode timing is the Medicare home health payment episode for which the assessment will define a case mix group, an early episode or a later episode in the patient's current sequence of adjacent Medicare home health payment episodes. Your options are 1, early, 2, later, UK for unknown, or NA, non-applicable, no Medicare case mix group to be defined by this assessment. Response-specific instructions. A sequence of adjacent Medicare home health payment episodes is a continuous series of Medicare PPS payment episodes, regardless of whether the same home health agency provided the care for the entire series. A LUPA, otherwise known as a low utilization payment adjustment episodes, less than 5 days total visits, are counted. Enter response 1 for early if the episode of care you are assessing the patient for the patient's first or second episode of care in a current sequence of adjacent Medicare home health PPS payment episodes. Enter response 2 later if the episode is the third or later episode of care in a current sequence of adjacent Medicare home health PPS payment episodes. Enter UK if the placement of this PPS payment episode is in the sequence of adjacent episodes is unknown. For the purposes of assigning case mix code to the episode, this will have the same effect as an early episode response. Enter NA if no Medicare case mix group is to be defined for this episode. If the patient needs a case mix code for billing purposes, a response other than NA is required to generate the code. Some payment sources that are not Medicare fee-for-service payers will use this information in setting an episode payment rate. Assessment strategies. Consult all available resources of information to answer this item. Medicare systems such as Health Insurance Query for Home Health, which is the HIQH, can provide this information. If calculating manually, note that Medicare home health payment episodes ordinarily comprises 60 days beginning with the start date of care, or 60 days beginning with the recertification date, and that there can be a gap of up to 60 days between episodes in the same sequence, counting from the last day of one episode until the first day of the next. Remember that a sequence of adjacent Medicare payment episodes continues as long as there is no 60-day gap, even if Medicare episodes are provided by different home health agencies. Episodes where Medicare fee-for-service is not the payer, such as HMO, Medicaid, or private pay, do not count as part of a sequence. If the period of service within those payers is 60 days or more, the next Medicare home health payment episodes would begin a new sequence. Remember that the 60-day gap is counted from the end of the Medicare payment episode, not from the day of the last visit or discharge, which can occur earlier. If the episode is ended by an interviewing event that causes it to be paid as a partial episode payment, or PEP adjustment, then the last visit date is the end of the episode. Mo140 Intent, time points, and data sources. Mo140 item intent specifies the racial or ethnic groups or populations with which the patient is affiliated, as identified by the patient or caregiver. Office of Management of Budget, or the OMB, regulations state that unknown is not a permissible response for this item. The major purpose for this item is to track health disparities. Time points that this is completed is the start of care, and it's updated if it changes during an episode. Data sources or resources would be the patient or family interview. If the patient does not self-identify, referral information, including the hospital or physician's office clinical data record, can be utilized. Also, observation. MO140 states what is the race or ethnicity. Mark all that apply. Option 1, American Indian or Alaskan Native. Option 2, Asian. Option 3, Black or African American. Option 4, Hispanic or Latino. Option 5, Native Hawaiian or Pacific Islander. Or option 6, white. Response 1, American Indian or Alaska Native. A person having the origins in any of the original peoples in the North and South America, including Central America, and who maintains tribal affiliation or community attachment. Response 2, Asian. A person having origins in any of the original peoples of the Far East, Southeast Asia, or the Indian subcontinent, including, for example, Cambodia, China, India, Japan, Korea, Malaysia, Pakistan, or the Philippine Islands, Thailand, and Vietnam. Response 3, Black or African American. A person having origins of any of the black racial groups of Africa. Terms such as Haitian or Negro can be used in addition to Black or African American. Response 4, Hispanic or Latino. A person of Cuban, Mexican, or Puerto Rican, South or Central American, and other Spanish culture or origins, regardless of race. The term Spanish origin can be used in addition to Hispanic or Latino. Response 5, Native Hawaiian or other Pacific Islander. A person having origins in any of the following peoples of Hawaii, Guam, Samoa, or the Pacific Islands. Response 6, white. A person having origins in only of the original peoples of Europe, the Middle East, or North America. MO150, Intent, Time Points, and Data Sources. MO150 Item Intent. This item is limited to identifying payers to which any services provided during this home care episode and included in the plan of care will be billed by your home health agency. Time points completed, start of care, patient tracking sheet, and updated if change occurs during the episode. Data sources or resources, referral information regarding coverage. This can be verified by the patient or caregiver. Copies of health insurance identification cards. This card will be provided and will provide a patient ID number as well as the current status of coverage. MO150 states, current payment sources for home care. Mark all that apply. Option 0, none. No care for current services. Option 1, Medicare, traditional fee-for-service. Option 2, Medicare, HMO, managed care or advantage plan. Option 3, Medicaid, traditional fee-for-service. Option 4, Medicaid, HMO or managed care. Option 5, workers' compensation. Option 6, title programs, for example, Title 3, 5, or 20. Other government agencies is option 7. This would be, for example, TRICARE or the VA. Option 8, private insurance. Option 9, private HMO or managed care. Option 10, self-pay. Option 11, other, which is you would document the response. And the final option is UK for unknown. Response-specific instructions. Exclude pending payment sources. Accurate recording of this item is important because assessments for Medicare and Medicaid patients are handled differently than assessments for other payers. If the patient's care is being reimbursed by multiple payers, for example, Medicare and Medicaid, private insurance and self-pay, etc., include all sources. If one or more payment sources are known but additional sources are uncertain, mark those that are known. Mark all current pay sources, whether considered primary or secondary. Do not consider any equipment, medications, or supplies being paid for by the patient in part or in full. Select response 2 if the payment source is Medicare HMO, another Medicare Advantage plan, or Medicare Part C. Select response 3 if the patient is receiving services being provided as part of a Medicare waiver or home and community-based waiver, HCBS program. Select response 6 if the patient is receiving services through one of the following programs. Title III. Title III is a state agency on aging grant, which encourages state agencies on aging to develop and implement comprehensive and coordinated community-based systems of service for older individuals via statewide planning and area planning. The objective of these services and centers is to maximize the informal support provided to older Americans to enable them to remain in their homes and in their communities. This program ensures that elders receive the services they need to remain independent by providing transportation services, in-home services, and caregiver support services. Title V. Title V is a state program to maintain and strengthen their leadership in planning, promoting and coordinating and evaluating health care for pregnant women, mothers, infants, and children with special health needs. In providing health care services for mothers and children who do not have access to adequate health care. Title 20. Social service block grants available to state to provide homemaking, chore services, home management, or home health aid services and enable each state to furnish social services best suited to the needs of the individuals residing in the state. Federal block grants may be used to provide services directed toward one of the following 5 goals specified by law. Title 20 Goal 1, to prevent, reduce, or eliminate dependency. Goal 2, achieve or maintain self-sufficiency. Goal 3, to prevent, neglect, abuse, or exploitation of children and adults. Goal 4, to prevent or reduce inappropriate institutional care. Or Goal 5, to secure admission or referral for institutional care when other forms of care are not appropriate. Select response 7 if the patient is a member of a TRICARE program, which replaced the CHAMPUS, CHAMPUS program. Select response 10 if the patient is self-pay for all or part of their care, for example with co-payments. This concludes the review of the OASIS items in the clinical records domain. Have a good day.
Welcome. This module reviews M1100, which is in the living arrangement domain. There are 2 key concepts that need to be understood so that this M item is answered correctly. The first concept is, what are the 2 steps to determine the answer to this OASIS item? First, we determine the living arrangement, whether the patient normally lives alone, in a home with others, or in a congregate setting. Second, determine availability of assistance. How frequently are caregivers in the home and available to provide assistance if needed? Only one response should be marked. Select the appropriate row, A, B, or C, to reflect the patient's living situation. Then select the one response in the column that best describes the availability of in-person assistance at the time of the OASIS assessment. Availability of assistance. Identify the frequency with which any in-person assistance is available. Around the clock means there is someone available in the home to provide assistance to the patient 24 hours a day. Regular daytime means someone is in the home and available to provide assistance during the daytime hours every day, with infrequent exceptions. Regular nighttime means someone is in the home and available to provide assistance during the nighttime hours every night, with infrequent exceptions. Occasional short-term assistance means someone is available to provide in-person assistance only for a few hours a day or on an irregular basis, or may be only able to help occasionally. No assistance available means there is no one available to provide any in-person assistance. Clinical judgment must be used to determine which hours constitute regular daytime and regular nighttime, based on the patient's specific activities and routines. No hours are specifically designated as daytime or nighttime. Availability of assistance refers to in-person assistance provided in the home of the patient. It includes any type of in-person assistance, including but not limited to ADLs and IADLs. If a person is in an assisted living or congregate setting with a call bell that summons on-site in-person help, this is considered in-person assistance. If its use is restricted to emergencies only, report the availability as occasional or short-term assistance unless the caregiver's availability meets a higher level. The caregivers need not live in the home with the patient, but assistance via telephone is not included in this question. This item documents the time caregivers are in the home and available without regard to the amount or types of assistance the patient requires, or whether the caregivers are able to meet all or only some of the patient's needs. Adequacy of caregiver assistance for different types of needs is captured in 2102. Use your professional judgment to determine if someone will be available to provide any assistance to the patient. If a person is living in the patient's home but is completely unable or unwilling to provide any assistance to the patient, do not count them as a caregiver. Availability of assistance refers to the expected availability and willingness of the caregiver for this upcoming care episode. M1100 Item Intent. This item identifies, using the care provider's professional judgment, A, whether the patient is living alone or with others, and B, the availability of caregivers other than home health agency staff to provide in-person assistance. Time points these items are completed, start of care, and resumption of care. Data sources, resources, patient and caregiver interview, physical assessment, observation, referral information, assisted living facility agreement or contract. Living arrangement. Select a response from row A if the patient lives alone in an independent, non-assisted setting. For example, a patient lives alone in a home in their own apartment or in their own room at a boarding house. A patient with only live-in paid help is considered to be living alone. A patient who normally lives alone but temporarily has a caregiver staying in the home to provide assistance is still considered living alone. A patient who lives alone but can obtain emergency help by phone or lifeline is still considered living alone. Select a response from row B if the patient lives with others in an independent, non-assisted setting. For example, if the patient lives with a spouse, family member, or another significant other in an independent, non-assisted setting, a patient who normally lives with others but is occasionally alone because caregivers are traveling out of town would still be considered living with others. Select a response from row C if the patient lives in an assisted living setting. Assistance, supervision, and/or oversight are provided as part of the living arrangement. For example, the patient lives alone or with her spouse or partner in an apartment or room that is part of an assisted living facility, residential care home, or personal care home. If the patient has recently changed their living arrangement due to their condition, report the usual living arrangement prior to the illness, injury, or exacerbation for which the patient is receiving care, unless the new living arrangement is expected to become permanent. Example 1. Patient lives alone in her own apartment. Since her discharge from the hospital, her 2 daughters alternate staying with her during the day and night so that one of them is always there, except for the times when one goes out to run an errand or pick up a child at daycare. Response 1. Patient still considered to be living alone, since daughters are only staying there temporarily. Daughters are providing round-the-clock care, even if one occasionally needs to be out of the house for brief periods. Example 2. A patient lives alone in her home, but her son and daughter-in-law live across the street. They bring the patient dinner every night and are available around the clock by telephone. Response 4. Son or daughter-in-law are not there to provide in-person assistance consistently, day or evening, even if they live across the street or available by phone. Example 3. Patient lives with her daughter, who works during the day but is home every evening and sleeps there every night. A paid aide comes in 3 days a week to assist with ADLs. Daughter has back problems that prevent her from lifting the patient, but she assists the patient with dressing every morning and takes the patient to doctor's appointments. We would select response 8. Patient lives in a home with others who are available every night to offer in-person assistance. Even if the daughter can't meet all of the patient's needs, she is available all night. Example 4. Patient lives with her husband who has significant cognitive and functional impairments, is wheelchair bound, and is unable to provide the patient with any assistance. A member of the church comes by one evening a week and brings groceries. We would select response 9. Patient lives in a home with another person who is there 24 hours but is unable to provide any assistance. Caregiver from church provides occasional assistance. Example 5. Patient lives alone in an apartment in an assisted living facility. The apartment does not have a call bell, but her contract with the assisted living facility includes having a home health aide assist her with ADLs 2 hours every morning. Her son also comes over occasionally to assist with bills, groceries, and errands. We would select response 14. Patient is living in a congregate setting. One caregiver is available to assist for some part of every day on a regular basis, but not all day. Another caregiver offers occasional assistance. This concludes the review of M1100, the Living Arrangements domain.
This module reviews the OASIS items of the sensory domain M1200 and M1242. M1200 item intent identifies the patient's ability to see and visually manage or function safely within his or her environment, wearing corrective lenses if these are usually worn. Time points item is completed is at start of care, resumption of care, or follow-up. Data sources and or resources, patient and or caregiver interview, observation, physical assessment, referral information, for example, H&P, which is the history and physical, progress notes, etc. M1200 vision with corrective lenses if the patient usually wears them. Response 0, normal vision, sees adequately in most situations, can see medication labels, newsprint. Response 1. Partially impaired. Cannot see medication labels or newsprint, but can see obstacles in path in the surrounding layout. Can count fingers at arm's length. Response 2. Severely impaired. Cannot locate objects without hearing or touching them, or patient non-responsive. Response-specific instructions. Be sensitive to requests to read, as patient may not be able to read though vision is adequate. Non-responsive means that the patient is not able to respond. As specified within the OASIS question, only assess functional vision with corrective lenses if the patient usually wears corrective lenses. A magnifying glass, as might be used to read newsprint, is not an example of corrective lenses. Reading glasses, including grocery store reading glasses, are considered to be corrective lenses. Physical deficits or impairments that limit the patient's ability to use their existing vision in a functional way should be considered. For example, if a physical deficit and/or impairment like limited neck range of motion prevents a patient from seeing objects in his path, affecting safe function in his environment, M1200 should be response 2, severely impaired. Assessment strategies. In the health history interview, ask the patient about vision problems, for example, cataracts, and whether or not the patient uses glasses. Observe ability to locate signature line on consent forms, to count fingers at arm's length, and ability to differentiate between medications, especially if medications are self-administered. M1242 item intent identifies frequency with which pain interferes with patients' activities with treatments if prescribed. Time points item is completed is at start of care, resumption of care, follow-up, or discharge from agency, but not to an inpatient facility. Data sources and/or resources. Patient and/or caregiver interview, observation of nonverbal indications of pain, physical assessment, referral information, for example, H&Ps or history and physicals, progress notes, etc. Standardized, validated pain assessment tools. Links to these tools can be found in Chapter 5 of this manual. M1242, frequency of pain interfering with patient's activity or movement. Response 0, patient has no pain. Response 1, patient has pain that does not interfere with activity or movement. Response 2, less often than daily. Response 3, daily but not constantly. Response 4, all the time. Response-specific instructions. Responses are arranged in order of least to most interference with activity or movement. Pain interferes with activity when the pain results in the activity being performed less often than otherwise desired, requires the patient to have additional assistance in performing the activity, or causes the activity to take longer to complete. Includes all activities, for example, like sleeping, recreational activities, watching television, not just ADLs. When reviewing patients' medications, the presence of medication for pain or joint disease provides an opportunity to explore the presence of pain, when the pain is the most severe, activities with which the pain interferes, and the frequency of this interference with activity or movement. Be careful not to overlook seemingly unimportant activities. For example, the patient says he or she sits in the chair all day and puts off going to the bathroom because it hurts so much to get up from the chair or to walk. Evaluating the patient's ability to perform ADLs and IADLs can provide Additional information about such pain. Assessing pain in a nonverbal patient involves observation of facial expression, for example, frowning or gritting of the teeth. Monitoring patient's heart rate, respiratory rate, perspiration, pallor, pupil size, irritability, or use of visual pain scales like the faces. The patient's treatment for pain, whether pharmacologic or non-pharmacologic, must be considered when evaluating whether pain interferes with activity or movement. Pain that is well controlled with treatment may not interfere with activity or movement at all.
This concludes Session 3 of Select Data's OASIS Clinical Education. Special thanks to Select Data team members Lisa Engel, Sarah Smith, and Tisha Smith for delivering this material. To reinforce what you've heard today, you are advised to refer to the session notes that will be provided for you from Client Services. For further reading and clarification of this material, the session notes also contains links to the OASIS Guidance Manual, Chapter 7 of the Medicare Benefit Policy Manual, and the CMS Conditions of Participation for Home Health. All of these resources are available on the CMS website. Do you have questions about this presentation? Please contact us via email at clinical.services@selectdatacoding.com. Learn more about how Select Data can help your agency with compliance and better patient outcomes. Visit us on our website or follow us on social media. Join us for our next session, which will review the patient history and diagnosis domain. My name is Deborah Johnston, and I am the Director of Clinical Services for Select Data. I look forward to spending time with you during our next session.